all of you and to see some familiar names. I'm going to share some slides here. Okay. So first of all, I think I'm supposed to have this slide. I have no commercial relationships to disclose. I am very honored to be with all of you today. As Marlene mentioned, I am a graduate of the medical college. Here I am on my graduation day with two of my colleagues, now a trauma surgeon and a dermatologist. I am aware of the Milwaukee Academy of Medicine's history and determined to make this 1,367th meeting of your organization, hopefully as inspirational as the very first. I would like to say thank you to Marlene, who's my colleague and teacher and friend, and to the Academy for extending me this invitation to talk with you. I'd also like to thank Angie for helping ensure that all of the logistics were worked out. As I typically do with these talks, I'd like to start with a story that will lead to our discussion. One very late night, as a resident, I sat in the middle of the pediatric intensive care unit with my supervising fellow and the hospital chaplain. A teenager that we had been caring for many weeks had just been allowed to die. She was 16 years old and she had lived with a rare neuromuscular disease that had progressed to the point that she couldn't breathe without the aid of a ventilator. And more devastatingly to her, she could no longer paint or draw. So she was taken off the ventilator, and then to make the process of dying less painful and less scary, she received significant doses of morphine when she became dyspneic. The nurses and the pharmacists who had been caring for her for years as she moved in and out of the PICU weren't ready or comfortable administering the drug they knew would hasten her death. And so it was my attending that drew up and administered the morphine himself, sitting with her and her mother until she died. Some days, the chaplain said to us as we sat sort of huddled together, some days we are called to the messy. I'm a pediatric emergency medicine physician, as Marlene mentioned in my introduction, but I became interested in understanding what promotes well-being among medical students and trainees and physicians over 10 years ago, and have been learning about and studying well-being ever since. My interest grew out of my work in quality improvement and the realization that I had early on in this work of the intimate connection between our own well-being as individuals and the quality and the safety of care that we provide to our patients. As I've learned about the depths of our unwellness as a profession and been witness to the messiness of medicine, my interests have shifted to advocacy. I now see the promotion of well-being and the support of those of us caring for others in the health profession as a moral issue. It is unconscionable that nearly 40% of us are depressed. It is unfathomable that over 4,400 physicians die by suicide every year. And it is unjustifiable that institutions continue to sideline our well-being to the realm of human resources instead of centralizing it and addressing it at the highest levels of leadership and pushing it to the forefront of every leader's strategic plan. And as we as a profession attempt to understand and work towards solutions, we must begin by acknowledging that many of the drivers of unwellness exist at the organizational and societal levels. When the canary dies in the coal mine, you don't blame the canary's lack of resilience. Organizational and environmental factors like productivity-driven staffing models, lack of diversity and inclusion, a culture of blame, and workplace violence absolutely drive our unwellness, as do societal factors like systematic oppression and structural violence that we may be impacted by personally, particularly if we are members of a marginalized community and bear witness to it regularly. When we begin to think of interventions, however, we start to dichotomize well-being into the aspects that are driven by these topics of systemic factors and those that are driven by individual factors. I think that in reality, these can't be separated. They are inextricably linked. What this means is that institutions can't offer modules on meditation or yoga classes at lunchtime and expect that this will bolster individuals' well-being enough to mitigate the impact of workload or compensation or an institutional culture that tolerates prejudice and microaggressions. By the same token, it's just as important to understand that our individual well-being, our capacity for compassion and empathy for our colleagues, our ability to self-regulate, our recognition of the impact that our presence, our biases, our attitudes have on those who are around us. That all of those things collectively contribute to the workplace culture and thereby the overall well-being of the institutions in which we work. Tonight, our objectives are focused on learning about the skills and practices and core concepts that you might use to improve your individual well-being, but with this understanding of how that fits in to that overall larger picture. To begin, I really want to make it clear that I don't define well-being by the absence of depression or the absence of suicidality, but rather by a more holistic vision that assumes that as caregivers, we might flourish. A vision that encompasses physical, mental, and emotional health, embracing joy, and finding meaning in the work that we do. Central to this vision of well-being, which is built on research and teachings from in and outside of medicine, is the idea that we are profoundly affected by the suffering of other people. In answering the call to care for other human beings, many of us, perhaps unknowingly, have also yoked our own healing and our own happiness to our patients. As such, what I hope you take away from our discussion today is a sense of how you might care for and alleviate the suffering of others in a sustainable and intentional way. In looking into our unwellness, one of the most prominent themes in the literature is grief. Grief and dealing with the compounding effects of loss. One of the most beautifully written articles I've ever encountered in the medical literature was published in the Archives of Internal Medicine in 2012. The authors sought to examine the nature and extent of physicians' grief over patient loss and its impact that it had on their lives. They just really beautifully compared the grief of losing a patient to smoke, that it was intangible, invisible, yet pervasive. Quote, sticking to our clothes when we go home after work and slipping under the doors between patients' rooms. The authors of this article worried about some of the clinician responses to grief that they uncovered in their study. Altered treatment decisions, mental distraction, emotional and physical withdrawal from patients. They found that unacknowledged grief can make us impatient and irritable. It can impact our treatment decisions and our motivation to recommend care. It can affect our ability to communicate about end-of-life issues with patients and families. Recognizing that it's impossible to compare my experience with yours, I would nonetheless like to share a story that taught me about grief and how central dealing with grief is to our well-being. I was at this time a third-year fellow in Denver, Colorado. So I was working in the department as the only attending physician. I received a call from paramedic base that an ambulance was en route and they were caring for a 4-year-old child. This child, I learned later, was the only son of Russian immigrant parents. They had earlier that day walked from their apartment to Baskin Robbins for ice cream. The little boy was sitting in the front of the store while his parents stood in line. A car traveling at high speed went through the store window after having been struck by another car behind him that was being operated by an intoxicated driver. The paramedics arrived quickly and found that the boy was pulseless and not breathing. They told me that they regained a pulse after intubating and giving a dose of epinephrine, and that they were bringing him to us for care. I was working with a resident surgeon and 2 experienced ED nurses. The rest of our team was in other rooms caring for patients who'd been injured at the same scene. We worked quickly and efficiently, but we knew right away that we couldn't save him. And it was the first time in my career that it fell to me to look up at the clock and call out loud to the room the time of his death. And then I walked from the trauma bay to the quiet room where his parents sat waiting. I told them that while we had done everything that we could, that their child was dead. What I remember most clearly was how loudly they cried. I sat and I heard questions that I couldn't answer. I held back tears. I finally stood up and excused myself from the room. And to this day, I can see myself on my knees in the back hallway of the department with my face in my hands. A nurse walked by and asked me if I was okay, and I quickly stood up and nodded and walked quickly and briskly back to my desk, proud that I hadn't let the emotions of the moment overcome my ability to run the department. One of the roadblocks to the acknowledgement of grief in our profession is that when you are surrounded by people who witness death and illness and tragedy as a matter of the course of their work, stories like these begin to fade into a collage of similarly heartbreaking stories. They become routine, so routine that we neglect to share them or to witness them for one another. Instead, we cry in hallways or stairwells or in the car on our way home. Author and internist Dr. Danielle Ofri writes, "Illness and death are integral aspects of medicine. The problem," she says, "is that the grief is largely unacknowledged. With no time or space to give grief its due, burnout, callousness, PTSD, and skewed treatment decisions are a risk." We see people die after protracted and difficult illnesses. We see lives devastated by new diagnoses or poverty or addiction. And then we kneel alone before rising quickly to take care of the next patient. We're not taught or given space to pace ourselves. Instead, we often function from a place of tremendous urgency. There is always another patient who needs us, another note that needs to be finished, another call that needs to be made, and it rarely feels as if we have done enough or that we are enough. I feel that as a group of people who witness both the desperation and incredible resilience of patients who face tremendous social injustice and unthinkable physical suffering, it's sometimes difficult to feel worthy of grief. I know that in those moments, after a resuscitation or a death in the emergency department, I often feel that my own experience of sadness somehow takes away from that of the parents or the family, almost as if there's only so much to go around. And while comparing our suffering to that of the patients comes from a loving and a kind place and can provide important perspective, it often leaves us feeling overwhelmed with guilt. Psychologists point to our intimate knowledge of death and of the limitations of modern medicine as potential reasons for why we process our emotions differently. The fact that many of us are high achievers who like to be in control, and that we become very good at hiding our emotions because it's a useful skill in some clinical situations. We're, of course, concerned about contaminating our clinical objectivity or appearing unprofessional. Over a year ago, while I was working in the ED, a consulting physician pulled me aside and asked why it was that the millennial physicians were so intent on talking about and dwelling on their emotions. We were taught, he said, that only the patient's emotions should matter. And while our views as individual physicians may be shifting, the idea that we must work to keep our emotions at arm's length, that our emotions shouldn't even matter, still lives on in our hidden curriculum and is entrenched in our professional culture. As Dr. Rena Oddish wrote in her beautiful book, In Shock, physicians are prone to all the same human emotions of pride and guilt and shame that distort our reason, but we are just trained to believe that we can surmount them. This training, I believe, has its roots in our profession's interpretation and application of the concept of equanimity. And this can be traced most directly back to Sir William Osler. In a speech delivered to the Pennsylvania School of Medicine graduating class of 1889, shortly before he left Philadelphia to become the first physician-in-chief at Hopkins, Dr. Osler explained to the newly minted physicians that there were two related virtues that would make or mar their lives. The first was imperturbability. Those that possess this physical attribute do not allow their facial expression or the way they carry themselves to belie the slightest expression of anxiety or fear. The second was equanimity, what Osler describes as the mental equivalent to imperturbability. By neutralizing our own emotions, he suggests we can more clearly see into our patients' inner lives. He also advises the graduates to meet their inevitable failures, their imperfect patients, and the uncertainty that is inherent in medicine with, quote, infinite patience and a cheerful calm. Over the last century, our profession has embedded this concept of equanimity into our professional code. The problem is, and I can't say that this is what Dr. Osler intended, we have also equated it more with stoicism, with mental toughness, with our ability to compartmentalize than we have with self-awareness, self-regulation, or empathy. And as I've dug deeper into understanding our unwellness as a profession, I'm increasingly interested in understanding what this sacrifice has meant for our well-being. What does it cost us? And what does it cost our patients? What I think is the more important question, the question I began asking myself many years ago when I became interested in this topic, is this: is there a better way? It's here that I want to shift from talking about what drives our unwellness and begin to learn about what might help keep us whole. I want to preface this by saying there are no multi-center, randomized, placebo-controlled studies that definitively point to interventions that, if implemented, will make us all well. There is no checklist. And frankly, despite the continued call for such studies, I don't really believe that even the most perfectly designed study will ever reveal such an intervention. In the studies I've done with medical students, it's quite clear to me that what works for one student or even a group of students is not going to work for everyone. And my experience as our hospital's professional health committee chair helped me to understand how locally even systemic drivers can act. Understanding this, I think we must shift from asking what works to asking what works for who, in what circumstances, and why. To do so, our team has shifted to using a quality improvement methodology and profile analysis in our work. And we push our leadership to see well-being as local, to offer a range of effective tools to measure well-being in an ongoing, iterative way. With those caveats, I want to share drivers of well-being adapted from a number of different disciplines that seem to play a role in the well-being of those of us who are in medicine. Because of the time that we have together, we're going to pay particularly attention just to 4 of these drivers: embracing vulnerability, self-compassion, mindfulness practices, and understanding the interplay of compassion and empathy. To start, I just want to talk a little bit about a course that I teach called Reach. This is a curricular thread for first and second year medical students aimed at teaching the skills and core concepts focused on well-being. The very first concept that we talk about is embracing vulnerability. When I talk about this, when I talk about vulnerability, I use the definition authored by Dr. Brene Brown, who is an author, researcher, and professor of social work at UT Austin. In her research, she defines vulnerability as uncertainty, risk, and emotional exposure. After interviewing thousands of individuals about happiness, she determined that the happiest people, those people who could fully lean into joy, were the ones who were not afraid to be vulnerable. These were individuals who could sit with pain or uncertainty or negative emotions like shame or sadness or anger. Brown found that while many of us spend a considerable amount of energy and time avoiding vulnerability, those that lean into it were more well. In speaking to physicians and advanced practice providers and nurses in my own institution about how they deal with the uncertainty that is part and parcel of our everyday work lives, there are consistent themes that come up, themes that echo what Dr. Brown found in her research. When we are uncertain, when we are in pain, we might numb ourselves with a few glasses of wine at the end of the day, or with the adrenaline that comes with overwork and overscheduling. We might allow our anger and cynicism to manifest itself in judgment of the next patient that we see, or the resident or medical student sitting next to us. Or we reflexively criticize that medical student, or the scrub tech, or our spouse, or our kids. My personal go-to strategy for avoiding vulnerability has always been perfectionism. I imagine, like many of you, I was raised to earn approval. Perfectionism is so alluring because there's this belief that if I look perfect and do all things perfectly, that somehow I can avoid blame and judgment and shame. In a profession that often feels as if it relies on blame and judgment and shame to maintain the status quo, being above that is very tempting. This is, of course, impossible and also exhausting, which is why my backup method for avoiding vulnerability is numbing. Numbing, which is described by a trauma worker and author, Laura Vandernoot-Lipsky, is an attempt to override our body's natural emotional response by either amping up the production of feelings to the point that one feeling is indistinguishable from another, or by shutting down the mechanisms for registering these feelings. So some people numb with alcohol or drugs. Some people numb, as I mentioned, with overwork or overscheduling. We're really good at inventing crises, particularly when it means we might avoid having to feel all that is happening around us. As Lipsky writes, action for its own sake keeps people moving, makes them superficially productive, and limits their capacity for reflection about their own lives. We can confuse this feeling of being amped up with being actually awake, actually present, actually effective. In speaking to clinicians across multiple disciplines, I have also seen tremendous courage in the face of uncertainty and pain. I've seen the willingness to sit with and be fully present for a family who was just diagnosed with leukemia. Pausing and acknowledging out loud the emotions that come up for a team when a resuscitation doesn't go as planned. reaching out to a colleague to talk about an unexpected patient outcome or a difficult decision that turned out to be the wrong one. When we show up like that, fully acknowledging that we have much less control over the outcome than we'd like, we of course open ourselves up to pain and suffering, but we also make it possible to then fully experience joy. The next concept that I want to talk about is the difference between empathy and compassion. In studies using a variety of modalities, including EEG and functional MRI, teams of social neuroscientists, here you see Richie Davidson, who is at the Center for Healthy Minds at UW-Madison, they have attempted to understand the differences in the neural circuitry between empathy and compassion. In one experiment, which is shown here, the French Buddhist monk, Matteo Ricard, who is actually known as the happiest person alive, was among those who were asked to listen to recorded sounds of a person screaming with a specific instruction to feel their distress, but to do nothing more. The pain centers of his brain during this experiment were active, and he reports struggling to continue. Matteo Ricard was then instructed to listen to those same sounds, but to also engage in something called compassion meditation, which is a process where you repeat silently phrases offering up safety and health and ease to that person. And in that case, his pain centers remained activated, but so too were the neural networks associated with love and other positive emotions. And he reports that he felt like he could do that indefinitely. Empathy, as we know, is affective resonance with someone else. It allows you to feel suffering when they suffer and to feel joy when they feel joy. Empathic resonance alone, as this and other studies suggest, can lead to emotional distress and burnout. We are entrusted with people's stories, with their very lives. We understand this as an incredible honor and also as a tremendous responsibility. In being responsible for the lives of others, we also become responsible to develop and maintain a strategy that allows us to remain whole and helpful to others, even amid huge challenges. I would suggest that while we want to create a space for and honor the hardship and suffering that our patients face, that we don't assume their pain as our own. Instead, as Ricard writes, empathy should take place within the much vaster space of compassion and love. The idea is that empathy directs our attention to where it hurts. And then compassion calls us to work to understand the levels of pain, the manifest and latent causes of it, so that we might effectively help and empower. I believe that one of the biggest obstacles we face in engaging with any of these ideas or tools that may improve our well-being is that on any given day, most of what we are feeling, or even how some of our avoidance or defense mechanisms are operating, typically happens beneath our level of awareness. What this means is that the crux of our work to be well and to thrive is really coming back in touch with the present moment. It's paying attention to how unresolved grief may be driving our decision-making, or how perfectionism and measuring our self-worth by how productive we are is preventing us from getting the rest that we need. And it's doing that over and over and over again. Oren J. Sofer is a meditation teacher. And for a number of years, he taught mindfulness practices to elementary school kids in Oakland, California, my hometown. Every time he met with students, he would ask them to share how they used their mindfulness since their last meeting. One morning, a little boy raised his hand and said, "My baby sister took my toy and I was really mad, but I used my mindfulness and I didn't kick her." As Jon Kabat-Zinn defines it, mindfulness means paying attention in a particular way, on purpose, in the present moment, and without judgment. We can bring this kind of attention to every moment of the day. You may bring it to your walk between your clinic and your office, or into the time it takes your computer to turn on, or into that moment that you turn the handle on the front door of your house. Paying attention in this way gives us the opportunity to see the connection between what we're feeling and how we're behaving. It allows us to respond instead of just react. In those moments when I'm resuscitating an infant in one room and there's a level 1 trauma on the way and the parent in room 7 is being arrested and ortho calls to ask, why can't I start the sedation sooner? I stop and I say in my head, where are my feet? Stay where your feet are. And I shift to feeling the physical sensation, the weight of my feet touching the ground, and I'm back to what it is I need to do right then. Or when I walk through the door at the end of a very long day and my kids begin complaining about what we're having for dinner or asking for more screen time, and I know that I have 25 notes to sign and a presentation to finish. I've practiced enough to know to stop and to allow that feeling of anger and frustration to well up in my chest, and then decide just to note it instead of yelling or becoming overwhelmed or shutting down, which is what happens when I react without awareness, when I attempt to ignore the anger and the frustration. While I've become better about paying attention on purpose, I still struggle to do so non-judgmentally. Being judgmental is sort of treated like an Olympic sport in my family, and medical school, residency, and fellowship taught me anything about self-criticism that I hadn't already learned. I will tell you, though, that the process of unlearning my instinct to punish and berate myself when I don't feel like I'm measuring up in some way has been absolutely key to my well-being. Pema Chodron, who is a Buddhist nun who lives in a monastery in Canada, teaches that self-compassion is the seed of well-being and the basis of compassion for others. In fact, Buddhism contends that compassion includes the desire to alleviate both others and one's own distress. I'm told even that the Tibetan word for compassion does not distinguish between compassion for others and compassion for self. As defined by Dr. Kristen Neff, one of the leading researchers in this area, self-compassion goes beyond speaking to ourselves kindly when we suffer, fail, or feel inadequate, although this is a key. It's also recognizing the universality of our experiences, remembering that we are not alone in our imperfection, in our suffering. And finally, it's being mindful of our inner narrator, observing our thoughts and feelings just as they are, without judgment and without trying to suppress or deny them. Last year, I attended, actually it was 2 years ago now, I attended a conference on self-compassion in Madison, Wisconsin, with Dr. Neff and her colleague, Dr. Germer, who is a psychologist on faculty at Harvard. And they taught us this exercise that I call one for me, one for you. So the next time you are listening to a patient or a spouse, a friend or a colleague who's experiencing some distress, I urge you to start by anchoring your awareness in your breathing as you listen. Begin to say silently to yourself as you breathe in, helping me, and as you breathe out, helping you. As the rhythm of breathing in and out becomes steady, you can say silently to yourself simply, one for me and one for you. The point is to feel the compassion flowing in for yourself and out for the other person. I use this in the ED a lot when I find myself being overwhelmed by what I'm hearing, or when my head is spinning with thoughts of the 25 other patients I'm responsible for in that moment. It can feel a bit weird to take the time to have compassion for yourself in these moments, or in any moments of personal pain or failure. It's certainly not something that we were taught or trained to do. But what I've noticed is that the way I talk to myself in those moments plays a very big role in how I move on. Admonishing myself for, say, not getting up to work out as I planned results in shame and self-defeating behaviors. I'm a total slob. I'll never have the motivation to get up and work out. I don't know why I'm even trying. But if I can speak to myself kindly, as if I was speaking to a friend in the same situation, this is not an easy thing to do. Plenty of people miss a workout. I'll go to bed earlier and I'll try again. I'm much more likely to pick myself up and wake up to my alarm the next time. What all these practices we've discussed have in common is the creation of space. We can do a lot to create that space as individuals and to be intentional about using that space to cultivate awareness, to recognize our emotions, to respond in a way that fosters compassion for self and for others. I also believe that this is where our institutions and our organizations can play a role by supporting the creation of this space. In RED, we've adopted something called the pause, which is now practiced widely and was first described in the literature by Jonathan Bartels, who was a nurse at the University of Virginia. After a death or a particularly difficult resuscitation, the team leader invites everyone in the room to pause for 30 seconds and to honor the life of the child and to honor the work that was done to try and save that life. The pause is like coming up for air when you're drowning. This very simple act is not a policy. We don't mandate that it happens in our emergency department, yet it has spread to our ORs and to our intensive care unit and to our colleagues in the Freighter emergency department. Because people have recognized that even this half of a minute gives us permission to grieve, to come down from the adrenaline surge, and to let our body's natural emotional state take over. It has so many layers to its importance. It's an act of compassion for the person who died and for their family, and it's an act of self-compassion for caregivers who feel those losses deeply. At Freighter, two physicians and friends of mine started a peer support program called Supporting Our Staff to help support providers, volunteers, and student learners experiencing normal reactions to abnormal patient-related events. Those events may include medical errors, unanticipated patient outcomes, the inability to stop the natural progression of a patient's medical condition, violence against healthcare workers, or the death of a colleague. Trained by Dr. Susan Scott, who is an expert in the second victim phenomenon in clinicians, a small group of physicians and nurses from our institution has since trained nearly 150 people, including physicians, nurses, advanced practice providers, techs, respiratory therapists, pharmacists, residents, medical students, administrative partners, and security personnel, all of who are looking out for one another and are ready to respond and refer anyone they feel needs support. The program is a 3-tiered approach to peer support. The first tier consists of anyone who's a member of the care team who understands potential high-risk cases that may induce a second victim response and can be a first line of support to a colleague in need. Second tier is the group of volunteers who have received specialized training in peer support, who are called upon by others to proactively provide support to a colleague who's in distress and who wear a little sticker on their badge shown there in the corner. The third tier is made up of experienced volunteers from our behavioral and mental health services, from social work, employee assistance, and others who are available to provide advanced support to a colleague when they're referred by a tier 2 peer supporter. The peer support team also meets quarterly to continue to adapt the program and to support one another. This has been so successful that we are now adopting the same system at Children's Wisconsin as well. The importance of this kind of support really can't be overstated. Again, in one of the most beautiful passages in her book, Dr. Oddish highlights how important this support is to our ability to continue our work amidst the challenges. She writes, "We cannot define success as beating death because death cannot be beaten. The undeniable fact of death remains, imposing and impending regardless of our temporary victories. How we care for each other during life is the true restoration, the definition of agency. Our ability to be present with each other through the suffering is what we are meant to do. It's what feeds us when the darkness inevitably looms. We cannot avoid the darkness, just as we cannot evade suffering. Loving each other through the darkness is the thing to look for and to mark. It's there in the shadows where we find meaning and purpose." What if together we reinterpreted equanimity in medicine as a state in which we allow ourselves to recognize and allow for all these emotions that naturally arise in the practice of medicine, in which we create enough space to sit with all the pain and all of the joy? Perhaps then our infinite patience and cheerful calm that Osler wrote about would then arise not from swallowing or denying our experiences, but from a balanced engagement with every aspect of being present for the suffering of others. Maybe then our compassion would arise not from pity for the person across from us in the exam room, but from a true recognition of what we share as human beings. Maybe then the stigma surrounding those of us who have entered medicine and struggled with deep grief, depression, anxiety, burnout, maybe that would begin to fade as we understand our feelings and our behavior as natural responses that flow from a place of compassion and humanity, from the part of ourselves that called us to medicine in the first place. I had the distinct pleasure of hearing Dr. Adam Hill, who is a pediatric palliative care physician, talk about his struggle with depression, alcoholism, and suicidality during grand rounds at the Craun Institute last year. And at the end of his talk, he expressed his gratitude that we had all become a part of his journey toward well-being and offered to be a part of ours. I would extend the same gratitude and invitation to all of you and want to welcome your comments and questions. Thank you very much for having me.
Thank you very much for an excellent presentation. I'm looking forward to any questions that we might hear.
I have a comment, Tom Russell here. Although I would wager it's less catastrophic and perhaps more shallow. And today's other occupations are dealing with the same problem. In today's Wall Street Journal on A10, there's an article saying seeking happiness. Harvard offers tips, and there are courses now at Harvard Business School and also at Stanford's Business School on dealing with unhappiness in high-achieving individuals. And the one, apropos to Dr. Ferguson's comment, the one at Stanford, organizational behavior number 374, interpersonal dynamics, is better known as touchy-feely. But they talk about some of the same things about being grateful and just approaching these same things. So I think it might be worthwhile just take a look at that as well, albeit it's not life and death as such, but other people are dealing with unhappiness and inadequacy and failure and not doing as well as they expect to be doing.
Mm-hmm. The class taught at Stanford, the two professors wrote a book recently actually called Connections, and it's about really just how we make connections with people throughout our day and how much that adds to our joy. And honestly, that's why I've always felt that really in medicine, we have this incredible opportunity and that we're privileged enough to be a part of so many people's lives. I just think that we also have to recognize in the same that we're really there for some of their most difficult moments, and the absorption of that suffering impacts us greatly. And acknowledging that's really important.
Dr. Ferguson, this is Dr. Angove in New Berlin, and I'm a general surgeon, retired. My niece is a pediatrician in Des Moines, Iowa. During her training, she had some emotional experiences with babies. When a baby dies, it just affected her so much that she thought maybe she should go into something else. But then during her training in the Children's Hospital in Springfield, Illinois, she had this training kind of like you're talking about. And that gave her the strength. Now she's a pediatrician for her own little daughter. But she's just enjoying being a pediatrician now.
Thank you for sharing that. It's so good to hear that we're talking about this in more spaces and that it's a part of people's medical training. That's really great to hear.
Mm-hmm.
My name is Bill Martins. I'm a retired obstetrician. Obviously, obstetrics deals with early pregnancy loss. 15 to 20% of early pregnancies are lost. These ladies feel just as much grief as those who lose a term pregnancy. It takes a special amount of caring to get these ladies through their grief. And some of them never get over it, and some of them are very successful.
Thank you, Dr. Martins. Yes, absolutely. I think that, and that can, again, it's that sort of idea of empathic resonance. If we are responsible for caring for people in those moments, those moments of just overwhelming grief and loss. And the idea here is that we should be learning how to care for ourselves alongside the learning that we're doing to care for other people. Really, those should go hand in hand. And that's our hope for the medical students at MCW, is that we can do that. I see Dr. Deer's question in the chat around how we might role model compassion and self-care to our learners who may fear they may be punished or graded poorly if they indeed show emotions. And I have students come to me all the time who feel, who may be witnessing suffering, who may be witnessing a patient's death for the very, death at all for the first time in their lives. And I think feel that fear very acutely, that if I cry or if I demonstrate any sort of emotion or emotional response to that, that I'll be sort of seen as not being able, not cutting it, not being strong enough, not being able to handle being a physician. And, I do advise them to ask questions. I think this is what medical students feel the most comfortable doing, is to ask questions, right? And so I encourage them in that moment to say something to the people around them. How have you dealt with seeing patients suffer. How did you feel when you first saw somebody die? And I think that helps physicians who may be a little bit out of touch with those emotions, right? Who've seen this so many times that they may have forgotten, to kind of get back in touch with those emotions, to it sort of, forces them to reflect on, yeah, that was incredibly difficult, and maybe sort of force a pause. I do think, though, there's a place for creating processes like the pause that I described in the emergency department that really forces that into the culture, right? So it's just expected that we're going to pause when someone dies or when there's a really difficult resuscitation. We're going to pause as a group. And I think that I've heard such amazing feedback, not only from medical students and from residents, but from nurses and other physicians who felt uncomfortable in those situations, just moving on to the next room. So I think it's a combination of both. And that's what I encourage students to do in those situations. I also see a question. One of the problems of our profession, and also in COVID times, is isolation. And that is the truth. Have you seen community developing to help people maintain healthier practices, and what kind? That is such a good question. I think our students are feeling very isolated right now. And I think perhaps getting a bit comfortable being alone, and not necessarily feeling embraced by the institution, embraced by a community that I really feel like you need in order to, endure the rigors of medical education, in order to make it through intact. And I don't know that we've figured that out yet. The REACH curriculum, which I described in brief during the presentation, what we've tried to do, so we have didactic sessions where we cover core concepts and skills, but then we also have small groups. So those are groups of 8 students who are led by 2 facilitators, a faculty facilitator, so someone who works clinically, and then a support or a behavioral health expert. So that person could be a psychiatrist, a therapist. We have psychiatry residents in that role, or student support staff. And they meet roughly monthly in their first 2 years. And they talk about all these topics that we talked about today. And what I've noticed is that those groups of 8 students have become communities in and of themselves. They've been able to meet outside of class. It gives them that connection. It builds in that connection and just facilitates the creation of community. So I think the more we do things like that, where we bring people together in groups that are small enough to really get to know one another and give them the opportunity to talk about topics that aren't necessarily covered and that are maybe a bit more vulnerable, I think we can move towards ending that isolation. And then there's another question, is to what extent does commercial pressures in American medicine compromise the physician's ability to exercise appropriate self-care? As a quality improvement person, this is one of my favorite questions, because as I mentioned at the very beginning, our unwellness is not an individual problem. It's really, the drivers of unwellness include systematic or organizational factors. Absolutely. And I answer this question in a lot of different ways. Because I do work in quality improvement, much of my time is spent trying to change the systems of care to bolster care providers' well-being, right? So changing systems in medical education, changing systems in the emergency department. And that's something that I think has to go hand in hand with talking about how we might improve our well-being as individuals. And so to answer your question, I think that they play a big role. And I think that we have to continue to sort of resist the argument that physician well-being is an economic issue, right? Like, we need physicians to be well so they can continue to care for patients and continue to sort of drive the economic engine that's medicine. I don't think that that is the right argument. I think we need to focus on the humanity. I think we need to focus on physician well-being as a moral issue, that we must find ways to improve the systems of care such that our physicians aren't depressed, aren't suicidal, aren't dying by suicide at rates that, exceed our professional colleagues. And that's what I continue to try to do.
Hi, I'm wondering what characteristics of work environments, organizations you're just talking about there.
So, I mean, again, I think those are very local. So one of the first things I did, I was the professional health committee chair at Children's Wisconsin for almost 5 years. And I really tried to understand what burnout looked like at our institution. What did unwellness look like? What were the drivers of it? And I started to do that by going and talking to every single section of the Department of Pediatrics, and then all of the divisions who worked at Children's, so surgery, for example. And I spoke with every single one of them. And I can tell you that while there were themes, for sure, there were themes across all of those divisions, every division had its very own problems. They were very particular to their local culture. And one example, I think, was the electronic health record. Epic was beloved by our anesthesiologists. They thought it made their lives, their work, much better. And it was a driver of their well-being. Not so for our psychiatrists, who write very lengthy, very detailed notes, and felt that time pressure was really limiting their ability to go home and be present with their families. They were constantly charting, after dinner and before bedtime and in the morning before they left for school. So there was very, even the same issue was perceived very differently across these divisions. So I think it's up to institutions to really dig deep into each of these local cultures and determine what is it that needs to be changed, organizationally or on that systemic level to improve well-being for that group. And there were, as I said, there were themes, and we really focused on trying to improve some of those things that cut across divisions. But it was very clear to me that there wasn't one issue that was gonna, or even 3 issues that solved would, make everybody well.
So I have a question.
Please.
Unless Dr. the other Dr. Jonathan, I know he tried to get in. If you have a question,
go ahead. I'll catch up after you.
Okay. Well, no, thank you for your talk. I'm a hospitalist, and basically my question is, when I see patients in the hospital, basically if they're depressed or anxious, I talk with them and then ask if they want to see a psychiatrist or not. And it really gets me with COVID. You hear these especially this emergency room doctor who died, in New York, committed suicide. And, I sometimes wonder if I'm good at detecting someone who's depressed and suicidal, a colleague. And I don't think I'm that good at it. And I'm wondering, but I'm pretty good at catching it. Although I'm not very good actually with patients either, but is it the same skill set or is it something different to catch a colleague or, another doctor who's just complains, which a lot of doctors complain. So it's hard to get, is this complaint real or is it, is this patient really, is this doctor really like, really sad and just wants to quit or wants to do something worse? Like, what do you have a story about that? Like, because I know stories of a doctor who saw a colleague and then that colleague killed himself or herself and it was terrible. I don't want to be in that position. Thanks.
Yeah, that's a really important question. I'm glad you asked. I think one of my very favorite quotes is from a meditation teacher named Sharon Salzberg. And she said, to pay attention is to love. And I think that we are trained to pay very close attention to what our patients say, their mannerisms, how they hold themselves. If you just look at how we describe people's mood and affect, we're looking for how they're dressed and whether they make eye contact. And we ask them very direct questions about being depressed or feeling as if they're, are they worried about hurting themselves? Are they thinking of killing themselves? We ask them very directly. It's a part of our training. That's what we're supposed to do. And that isn't true of our colleagues. That's just not a part of our culture necessarily, right? That's not how you interact with your people that you work with. I think that we have gotten to the point in our profession that it should be a part of that. And I think, again, getting back to this idea of making space, how might we create space in our work environment, in our offices, in the places that we meet for faculty meetings, for example? How might we make space to have these really vulnerable conversations about how we're really doing? In our section in emergency medicine, I had so many people reaching out to me saying, I'm struggling. I'm not doing well. I might be depressed. I might be anxious. That we started to talk about it with everybody within our faculty meetings. I think bringing it to the awareness of everybody makes it feel okay to talk about. And so, in addition to making sure that everybody has resources related to therapists and psychiatrists and knowing who they can pick up the phone and call, we also have what I call group therapy. About once a month, we've had one of our psychologists at MCW come on in and sit with all of us, and we talk about what's gone on that last month. And it gives us the opportunity to check in with one another, but it also gives us the language then to leave that room and approach a colleague and say, what we were talking about was really hard. Like, what's going on with you? And I think it just makes it okay. It makes it a part of our routine. And I would encourage everybody to start to think about doing that in their own places.
Hi, Jonathan Burkhoff, OBGYN. Thanks for the presentation. So refreshing, so nice to see the evolution of our behavior over time. I hope it continues, and I'm a big fan of Richard Davidson. I've heard him speak. But I'm just kind of curious because I've always sort of hung on to the words of Osler in that speech and found it very useful, actually. As an obstetrician in times of chaos, you're in an operating room, or in the emergency room, and equanimity for me had always been interpreted as the ability to remain calm as the leader of the team, as the one directing traffic, as the one trying to make sure that you're not in a sense of panic that would engender panic in others, and some level of confidence that the patient has that you've got this under control, whether you may feel that way or not. I found it to be useful and productive. And I never felt like at the end of that, whether there was, something that needed to be done emotionally for myself or for my patients, I didn't feel like that equanimity that I was tapping into during the crisis prohibited me from being emotive, compassionate. And so I never carried that same kind of containment of emotion after the event was over. It just got me through the drama. And I've been very open throughout my career to the kind of work that you're doing. And I find it fascinating and helpful and healthy to pursue all of that. But I still, when I go to work, if I'm in a crisis, equanimity is a tool I use. So I'm just wondering, if you find that, because the sense I got from your speech was that was sort of the root of the evil, the battle that you're fighting. And to me, it seems like it's part of the process. And I'm also curious about, if Osler were here today, in some sense, at least he was tapping into what goes on in a physician's mind. He was speaking about the emotions of a doctor, and that may have been a fairly novel concept as well. I've not gone back historically to find out whether it was even talked about how a doctor should or shouldn't feel. But maybe the conversation beginning about how we should feel as physicians, maybe he would be part of this solution today. It's a curiosity of mine.
Mm-hmm. No, I very much agree that I think Osler talked about emotion in a time that it wasn't talked about, particularly just having emotions in the face of, taking care of another person's suffering. I'm not necessarily, I don't have a problem with what Osler said in his speech. I think where things maybe have gone off track is in our profession's interpretation of what he said in that. This idea, and I think rather than equating equanimity to more of what really I would describe as sort of a Buddhist take on equanimity, which is, I think, what you're actually describing, this idea that we can be present with chaos and still be calm, that we can be present with with suffering and with joy and hold them both at the same time. Mm-hmm. That for me is where I think equanimity has been so useful, both in resuscitations, as well as sort of reflecting on those resuscitations afterwards. I think where the problem has come up is when we equate that sort of imperturbability or equanimity with the neutralizing of our emotions, or sort of this stoicism, this like mental toughness that, and feeling as if we have to that we have to portray that at all times, both with our patients, with our colleagues, with our trainees, in our homes. And that's what I hope. It's really more of, I'd like to think about reinterpreting equanimity as Osler described it. But thank you very much for your comments. I appreciate the opportunity to clarify.
Thank you.
It is 8:15, and we thank you very, very much for this excellent presentation. very thought-provoking and certainly timely as we experience the challenges of COVID and changes in the way medical care is delivered and organizationally, et cetera. So thank you.
Thank you. And thanks for having me. Nice to meet all of you.